And here we are, Dr. Lee, you're good.
Awesome. Thank you so much for everyone who has joined us today for the Podesnak Institute, Longevity Institute, Geroscience Center Grand Rounds. I am delighted to introduce our speaker today, who is Dr. Ken Schmader, who's professor of medicine at the Division of Geriatrics at Duke University Medical Center, where he's also director of the Duke Pepper Older Adult Independence Center, as well as the GREC, the Geriatric Research Education and Clinical Center. He serves on the working group for the Herpes Zoster Influenza General Adult Immunization Guidelines for the CDC Advisory Committee on Immunization Practices, the ACIP, and is the American Geriatric Society liaison to the ACP. And his areas of research, in case you haven't gleaned it yet, is herpes zoster infections and vaccines in the older adults. So I am delighted to introduce him, and thank you so much for talking today to us, Dr. Schmader.
Hey, Bentley, thanks so much for the introduction, and it's great to be here, and a real honor to speak at Northwestern Geroscience Academy Grand Rounds. I had to tell you, I was telling Lee beforehand, Northwestern is a very special place for me and my family. My son got his PhD in cognitive psychology at Northwestern and worked in that department for a few years. And my daughter was the assistant director for the Northwestern Office of Global Marketing and Communication, Kelly. Now she's the one on the left, of course. And here she is working on a capital campaign for Northwestern. So it's really wonderful to be here speaking to you. Now, it's a really interesting and exciting era in vaccine science, and it's been great to be involved with this. It is literally changing the landscape of clinical practice in older adults. So there are basically two things I wanted to do with you today. One is to get you to understand these advances that, in my view, enhance resilience to infectious stressors in older adults. And the other is to illustrate these advances specifically in the case of zoster and the recombinant zoster vaccine, and something I've been working on for a long time. And all of this relates to geroscience and immune resilience, as you see as we go along here. All right, so I'm going to start with patient presentation in classic Grand Rounds tradition. This is a 78-year-old man who's actually in good health, working as a CEO of a company, who came in to see me because he had developed zoster. And I asked him, tell me your story. What's going on? And this is what he first said to me. I've had postherpetic neuralgia from the start of shingles until now. I don't know, it's been 50 some days. The pain has worn me down to the last straw. I am at the end of my line. I've got to have somebody do something. I desperately need help. I don't know how much longer I can take it. And I wish you could hear the desperation and suffering in his voice. It's really quite terrible. In fact, occasionally this kind of severe zoster pain leads to suicide. So the seeds of this man's suffering were sown about 70 years ago when he was infected by this virus, varicella zoster virus, or VZV. It's a double-stranded DNA herpes virus, and around the DNA is a liver protein envelope. I hope you can see my pointer here. Now, in that envelope are glycoproteins that you can actually see on this EM. And the most abundant glycoprotein is glycoprotein E. I want you to remember that. We're going to get back to it later. Now, after primary infection, VZV has this remarkable ability to establish a latent infection in dorsal root and cranial nerve ganglia. It's not eliminated from the body. And this is a schematic of VZV latency and reactivation. We see the ganglia here, the sensory nerves going to the skin. These little black dots are meant to be virus here. And it just doesn't sit there quiet. What it does is it periodically expresses proteins on the nerve cell surface, or it can start a productive infection. But our cellular immune response recognizes it and stops it, right? And this is going on in the background all the time. Unfortunately, with aging or disease-related decline in cellular immunity, this reactivation event can escape immune containment and start spreading in the affected ganglia, which is shown here, and eventually down the sensory nerve to the skin. Before it reaches the skin, the patient's often experiencing a prodrome of pain or paresthesias, which can be really confusing to patients and clinicians. I can't tell you how many misdiagnoses I've seen with this. But then when it reaches the skin, it often becomes easy to diagnose, which, believe me, is such a pleasure in geriatrics. We have so many vague syndromes and things we have to deal with. So here's the classical rash of zoster. It's got a red macular papular base, and you can see these little blisters here. It's unilateral. It's in one area innervated by that sensory nerve. That's called a dermatome. It's dermatomal. It's zoster. There are about 1 million cases of zoster each year in the United States. The lifetime risk is 30%. All right, here's another zoster rash. It's basically showing the vesicular phase really nicely. And it reminds me to tell you that these vesicles are teeming with virus. I mean, really hundreds of thousands to millions of virions. The virus can be transmitted from the vesicles to someone who's never before had primary infection. And the disease that person gets is chickenpox or varicella, not zoster. There's a common misconception about that. Zoster is always from the endogenous reactivation of your own virus. And most people in the United States are latently infected with the VZV or they've been vaccinated, so they're not at risk for developing varicella, all right? You want to see some more rashes? Come on, I know you do. Let's do a couple more, all right? Here's a classical zoster rash, and the point here is that there are branches of the sensory nerve that go anterior, laterally, and posterior, and this is beautifully demonstrating that. Here's the anterior branch involvement, here's the lateral branch, and here's the posterior branch, even with the vesicles. Okay, now this is zoster. It's hard to believe, isn't it? It looks different. These widespread red, discrete macular and ulcerative lesions that you see here with the crusting. And this patient didn't have any pain, by the way. And although it doesn't look like a typical zoster rash, this is an example of a disseminated zoster rash in a patient with lymphoma, an older adult. And this is due to the inability of the cellular immune response to contain the hematogenous spread of the virus. Okay, so now this reactivation event in zoster is highly age-related. This shows the age and incidence of zoster. Here's the vertical axis is incidence rate of zoster versus age group here in 13 different countries. And look at this reproducible increase of zoster with aging, starting in the 50s, but the absolute number of cases are mostly in the 70s and 80s. Now, importantly, the chronic pain that comes along with zoster, that is post-herpetic neuralgia, can be superimposed on this map, its incidence. It looks just like this. So it goes up dramatically with aging. And here's an example of ophthalmic zoster, zoster perfectly outlining the ophthalmic division of the trigeminal nerve. And it's in the crusted phase. And this rash looks nasty. By the way, she's got ocular involvement too, so she has visual impairment. But that's not what was bothering her. What was bothering her was 11 out of 10 ice pick stabbing behind the eye kind of pain, to the point we had to admit her, right? So this pain, both acute and chronic, is something we absolutely want to prevent, don't we? Now, for a conceptual approach and how we thought about preventing this disaster, I want to apply a resilience lens, right? And this is our resilience conceptual model from the Duke Pepper Center. Our theme in our Pepper Center is to understand and optimize reserve and resilience in older adults. And we define resilience as the ability to resist or recover from an adverse effects of a health stressor. So we focus on functional status and whole person function, and also molecular parts of resilience. We're not experts in psychosocial resilience, and believe me, there's a lot of interesting literature on that as well. But that's our focus, bouncing back after health stressors. I want to make you aware that there's a trans NIH working group that we are also a part of that is developing a definition they want to use across all the institutes of the NIH. It's led by Laverne Brown in the Office of Dietary Supplements. And they define resilience as a system's capacity to resist, recover, or recover better or grow in response to a challenge or a stressor. So a couple of important things in this model. We view resilience, and everyone does who works in this area, as a dynamic response. It's something that happens over time, and there can be good recovery. There's some of this bouncing ball. Some people do well, and some do not do well, right? And the stressors are multiple that can be combined. For the purposes of my presentation, we're talking about an acute illness like zoster and the pain that comes along with it. And then very importantly, pre-stress reserve that's the reserve or the capacity we have to adapt to the health stressor. And this is where vaccines play a role. What we're trying to do with vaccines is build reserve here so people can withstand that threat of an infection, right? But we basically face two big barriers in doing this with older adults. One is the wide heterogeneity of health states in older people. These people are all about the same age, but you can tell we have the range from someone who's very robust, usual aging, to someone who's quite frail. And it's not hard to understand if you put a vaccine in this person's arm, or you put a vaccine in this person's arm, you're going to get a different response, right? And also, clinical trials don't usually include these individuals, the frail individuals. The other barrier that I'm sure you know as I'm talking, but we have to say it, is immune senescence, right? That is immune dysregulation with aging and immune dysfunction and inflammaging, if you will, one of the geroscience pillars of aging. So the left side of the panel shows the usual healthy immune response to a vaccine. But on the right, we have changes in the immune response to vaccination with aging. The easy way to remember this is there are age-related defects in the innate immune response and the adaptive immune response. The innate immune response, there are definitely changes in the number and function of antigen-presenting cells, which in turn can feed into decreased T cell activation. And then on the adaptive T cell response side, we know that there are changes that lead to diminished T cell immunity, and it also affects the B cell arm with decreased B cell function, right? So here are those two big barriers we're working against. So we're thinking about this with zoster. So our first approach to try to overcome this and prevent the suffering that goes along with zoster was this live attenuated zoster vaccine. This is a live attenuated vaccine that contains whole live virus and viral antigen, and it actually replicates when you put it in the arm. What a perfect immune stimulus, right? That's what we thought would be really good when we were testing this. And by the way, when we started working on this, it was in the 90s. It shows you how long it takes to do some of this stuff. And so our first intervention to try to prevent zoster was using this live attenuated vaccine in a much higher dose than the chickenpox vaccine in the shingles prevention study. And this is a unique study, a landmark trial. It was a VA cooperative study that is done in collaboration with Merck. It was a public-private partnership. Huge phase 3 study, over 38,500 subjects. And I actually was in charge of the recruitment arm of the methodology. Believe me, I laid awake at night wondering if we get these individuals. We did. And look at the results. The vaccine prevented zoster overall by reduced it by 50%. And it was around 64% in 60 to 69-year-olds, about 38% in those over 70. But interestingly, with aging, the effect on PHN did not decrease. It reduced it by 2/3 in everyone over the age of 60, which is quite remarkable. And then we did a large study in people over the age of 50 to 59 and showed a vaccine efficacy around 70%. So let's take a pause here. All right. This is a landmark trial because it was a scientific proof of principle that we could prevent a reactivated infection. All other vaccines prevent primary infections. And believe me, there was a lot of skepticism as to whether this was going to work, mostly because herpes simplex virus vaccines have not worked for preventing reactivated simplex. All right. And this was a clinical advance because it was a good, solid vaccine. It had solid protection, was typical of other vaccines in older adults. So on the basis of the study, the FDA approved the live zoster vaccine. At the ACIP, we voted to recommend it. It was added to the adult immunization schedule in 2006. The company name was Zostavax, you may remember it. But you know what? There was something was going on. As we started following things over time, it became clear that people were developing breakthrough cases of zoster. In fact, we did a more formal study of this, looking at the efficacy of the live zoster vaccine against zoster by year after vaccination. This axis shows vaccine efficacy, with 0 being it's not effective at all, and years after vaccination. So good protection, decent protection out to about 5 years. It starts waning. So we thought, well, maybe what we should do is give a booster dose of the live vaccine. And we actually did the immunological studies and it showed good responses, but something was changing. And now we're in the 2010s and our technologies for developing better vaccines started increasing dramatically. And we thought, well, maybe we should look at those technologies. And what were those? All right. It's these two. These are the two I want you to remember. It truly is a new era in vaccine science. We truly have engineered better vaccines. And it's based on these two things. One are newer adjuvants, much more potent adjuvants. The other is the use of recombinant nucleic acid technology. Okay. So adjuvants are simply substances that potentiate the immune response to an antigen. And there have been adjuvants in vaccines for a long time, but kind of weak, alum or aluminum, for example. But now we have much better adjuvants. In fact, with the NIAID, there's an adjuvant work group that meets on a regular basis, and they have a whole adjuvant strategic plan. And I think this is going to continue to get better, right? It can be used for quite a number of things shown on this slide, but what we're interested in vaccines for older adults, right? And the other thing is recombinant nucleic acid technology. Now, this involves using enzymes and lab techniques to isolate DNA or messenger RNA genes that make the antigens of interest that we want that will stimulate the immune response, right? So it's more precise, the more defined specificity. And here are the basic platforms. One are protein platforms. And here, the technology is used to put a gene in a cell system that makes the protein or proteins of interest. You harvest it and purify it from the supernatant and then usually pair it with an adjuvant. With viral vectors, we put the genes of interest into the it's usually an adenovirus vector, to be honest with you, in that genetic backbone. It's injected as a vaccine, and the host muscle cells take that up, and the host machinery transcribes the genes for the immunogen and starts the immune response off. And then there have been nucleic acid vaccines, DNA and mRNA vaccines. These are the pieces of DNA or mRNA that have the genes of interest. They're associated with a carrier molecule that allows it to get into muscle, and then that's transcribed, right? Now, these platforms existed before COVID-19, but I'll bet you anything that you know these. mRNA, yeah, I know what those are. The only good thing about COVID-19, as far as I'm concerned, is that it hyper-accelerated the development of these platforms and vaccines. So remember those platforms, and now let's move on to specifically talk about how we did this with Zoster, all right? So here's the structure of the recombinant Zoster vaccine. The company name is Shingrix. It consists of one antigen, glycoprotein E, the one I told you about earlier, and in combination with this adjuvant system, AS01B, that actually has two adjuvants. One is monophospholipid A, and the other is saponin or QS21. Very powerful potentiators of the immune response. And together, this makes the vaccine, okay? Now, when the testing was done with this vaccine, initially for the immunological responses, the cellular immune response was quite good. It was quite high. The problem was there is no known correlative protection against Zoster. In other words, there's no immunological measure I can tell you that, yeah, you're definitely protected against Zoster. So the only way to know whether this worked was to do phase 3 trials to see if it did. And these are the phase 3 trials that are also landmark trials like the shingles prevention study. The Zoster efficacy 50 and the Zoster efficacy 70, that's in over the age of 50 and over the age of 70 RZV trials. Classical randomized double-blind placebo-controlled trials in people over the age of 50 and 70 by these 10 years age strata in immunocompetent adults with no prior Zoster at multiple centers around the world. The intervention was 2 doses of RZV or placebo, 2-month intervals. A little different than what we did with the live attenuated Zoster vaccine, which is just 1 dose. There's a bit of a prime and then a boost with the 2 doses, with incidence of Zoster and PHN as the outcomes. All right, let's go to the punchline. What actually happened in the trial is shown on this figure here. It shows the incidence of Zoster in this axis, the age groups down here. These are Zoster 50 and 70 pooled analyses. The blue bars are the incidence in the placebo group, The orange bar is the incidence in the RZV group. And by the time I've got you oriented to the slide, V is vaccine efficacy, you can see the results are spectacular. All right. It reduced zoster by 96 to 97% in people 50 to 70. It reduced it by 91% in people over the age of 70 and over the age of 80. I mean, these are the kind of results we get with childhood vaccines. This is what you see with kids who get the measles vaccine. So again, like the shingles prevention study, let's take a pause here. This is a major clinical and scientific advance. It's a clinical advance because it's clearly an improvement in vaccine efficacy over the live attenuated zoster vaccine. And it has the efficacy that's similar to childhood vaccines. This is over a 3-year period. And now we're doing follow-up studies and it's good out to at least 5 years. And the immunological response has been good out to 10 years, right? It's a scientific advance because there's something about this adjuvant that is overcoming immune senescence. And why that is, I don't know. I'm not an immunologist, but there are people working on it and I hope they find out soon. Okay, now you may wonder, yeah, gee, these results are so good. Is there a price we pay for this? Well, there is kind of, sort of, but before we get to that, one thing I wanted to mention is that we wondered, what about vaccine efficacy in frail individuals too? So we'd actually collected a fair amount of information that allowed us to measure frailty using Rockwood's deficit accumulation approach. So we did this study of measuring frailty in over 26,000 individuals in these Zoe 50 and Zoe 70 subjects. And we're able to figure out who was non-frail, pre-frail, and frail. And the bottom line is that even in the frail individuals, vaccine efficacy was 90%. So that's a really interesting finding, and one of the few studies that actually focuses on frail individuals with vaccines in older adults. Now, the price you pay is reactogenicity. This is definitely the most reactive vaccine we have for routine immunization in older adults. This shows local and systemic adverse reactions in the pooled analyses from these studies. So here's the event on this column, and it includes injection site pain, then muscle aches, fatigue, headache, shivering, and fever. And you can see the frequencies. And this is definitely more frequent than, say, influenza vaccine, for example. There are a couple of important points on this slide. One is go across the row, and it doesn't matter what row. The older you get, the less reactions there are. So one of the few advantages of aging is you become a little less reactive to vaccines. It doesn't bother you as much. And in fact, the other thing to look at are these grade 3 reactions. Now, grade 3 reactions are defined by the FDA and the CDC and industry as prevented normal activity, which, believe me, for those of us in geriatrics who do more sophisticated measures of function and quality of life, that's kind of laughable, isn't it? And we have done more sophisticated measures of the impact of grade 3 reactions on quality of life and physical function, and it can be quite impactful. But look again, the grade 3 reactions decline over time. But compared to other vaccines, these are fairly high. If you look at the whole person as a unit of analysis, about 16% of people over the age of 50 develop grade 3 reactions, and about 11% of people over the age of 70. So it's really important to counsel individuals ahead of time that, this vaccine can throw you for a loop for a couple of days. I not want to do strenuous activities for a day or two after you get the vaccine. It's quite heterogeneous. Some people get it and they can't even tell they got the vaccine. They thought they got water. And there are others that do have, pretty significant fatigue and muscle aches when they get the vaccine. And by the way, the other interesting thing here is whether you got reactions or not, it's still quite effective. Okay, so because of these kind of results, obviously the vaccine was added to the adult immunization schedule a few years ago by the CDC, authorized by the FDA, and here it is. These yellow bars represent vaccines that are recommended for all persons over the age of 65 or anybody in these age groups, right? And so here are the kind of the big 5 for older adults. And what is important here is that everything I talked to you about for these advances in vaccine science are affecting almost all of these vaccines now. So the COVID vaccines use all of those platforms I mentioned. Influenza vaccines. We have a adjuvanted flu vaccine, that's Fluad. We have a recombinant influenza vaccine, that's Flublok. For the recombinant zoster vaccine, we talked about that already. And then the pneumococcal conjugate vaccines have gotten better over time. We've got some newer PCVs, and that protein conjugate is acting as an adjuvant as well. So, by the way, the most interesting thing and the newest addition to this recommendation for RZV is it's now recommended for immunosuppressed patients, all immunosuppressed patients over the age of 19 as well. Okay, now I'm going to finish up by talking about another way of looking at this. Right, all along here, I've been focusing on the vaccine and advances in vaccine platforms. But you also can focus on the person receiving the vaccine, and that is improving biological aging mechanisms, our geroscience pillars of aging that may enhance vaccine response. And this is really an interesting area of research. A few years ago, the NIA sponsored a workshop on physiologic resiliencies in human aging. It was published in the Journal of Gerontology down here, and I was honored to be at that workshop and be a presenter. And we put together a table that's in that paper that looked at influences of biological aging-related mechanisms on type of resilience. And here are these geroscience things we know well, right? Cellular senescence, stem cell exhaustion, inflammaging, immune modulation, and mitochondrial dysfunction, et cetera. And all of these things we know affect immune responses that can affect infections and vaccine responses as well, right? So then, it kind of raises the question, can geroscience-based interventions that target biological aging improve immune resilience and clinical outcomes to infections and vaccines? So this figure is taken from a really nice article in Geroscience from Jamie Justice et al. That uses metformin as one such example of a geroscience intervention. As many of you may know, metformin has pleiotropic cellular effects on key pathways and the hallmarks of aging, and it includes immune modulation and anti-inflammatory effects. So in the left panel, the hypothesis is, well, if we initiate metformin prior to acute infection, maybe it will improve resilience, resulting in fewer events like hospitalization, briefer recovery time, improve recovery to baseline health. And then also for the longer term, on the right panel here, if we're using it more chronically, perhaps it'll result in greater long-term health effects, which could be observed as improved vaccine responses and reduction in the impact of age-related chronic disease and geriatric syndromes here. Now, this is an hypothesis, and it could be some other geroscience-based intervention, maybe senolytics, rapamycin, mTOR inhibitors, et cetera. But there are pilot studies going on now of metformin use and immune responses to influenza and pneumococcal vaccines in non-diabetic individuals. So it'd be very interesting to see what goes on. I think this is a really interesting open area of science and geroscience now. Okay, this is my last slide. Actually, technically the next to last slide from the thank you slide, but this is what I'm calling the grand vision slide, all right? This figure shows the age-related activity of VZV in a population, and it was put together by Dr. Tom Weller. Many of you are probably not aware of Dr. Weller, but he was a great Nobel Prize winning virologist who, among many things, discovered that the virus that caused varicella chickenpox and the virus that caused zoster or shingles was one and the same, because when he was doing his work then, it was the 1940s at Harvard, they were thought to be due to two separate viruses. And he named it the varicella zoster virus. All right. Weller was a giant, and I had the great misfortune of meeting him, and they had a mentor-mentee match at an international meeting, and I was lucky enough to be paired up with him. A wonderful gentleman, and after I'd expressed my awe and asked him a million questions, he said, "What's your specialty?" And I said, "Well, Dr. Weller, I'm a geriatrician." And he was 80 years old at the time, and he said, "Really? That's fantastic. I want to tell you, I'm having a lot of trouble with my hearing. My joints are bothering me. I'm not as mobile as I used to." And the next hour, we talked about geriatric syndromes. It was fantastic. So he put together this great slide, right? And this is age-related activity of VZV in a population, a review article in England Journal from 1983. All right, cumulative percent of the population involved. And this fine stippled area is varicella. And, just about everyone in the US population is latently infected with VZV or vaccinated. We'll talk about that in a second. But like I said, it doesn't go away. So this gray area here represents latent infection. And then with aging, here's zoster increasing. So the whole idea is to give varicella vaccine here early in childhood to get rid of varicella and give zoster vaccines here to get rid of zoster. So what's actually happened over time is since the start of its about 25 years ago, the varicella vaccine program in the United States has led to a 97% reduction in cases of chickenpox. So this curve has flattened out. We don't see chickenpox anymore. It's amazing, right? And now we've got the zoster vaccine. Unfortunately, the uptake in older adults has only been about 39–40%, and some of that's Zostavax and some of it's now Shingrix. But we have the tool now to flatten this curve. And interestingly, the most recent data from the CDC shows that zoster is starting to decline in people over the age of 60. So maybe we'll be able to neutralize this enemy of older adults completely with VZV. All right, and with that, I'll conclude my comments and thank you very much for your attention. I love this slide because they're in the back of a grocery store that says eggs here, and everyone's getting their flu vaccine, so you gotta love it. And thanks again. Happy to answer any questions.
Yay! Thank you so much. That was a very interesting talk. And I also love this slide too, because I would almost bet that the vaccine might be refrigerated next to the eggs.
Great job, Lee.
I'm just thinking, all the good stuff that goes on. One of the things that struck me with your talk is that so much of what the ACIP is doing and what we know about vaccination is for people that are over 65. But when we get patients that are moving into their 80s and 90s, how do you think resilience is changing when people reach into their centenarian ages almost, 90, 100s? Yeah.
A great question. I think basically remember that conceptual model of reserve, that reserve is declining over time. And I know you've seen this a million times clinically, Lee, that when you get in the 80s and 90s, that capacity to respond to that threat is quite narrowed. So the idea then is what can we do with very old people for building that reserve? And that's the thing that's amazing about the recombinant zoster vaccine studies that just blew us away is that people in their 80s actually did very well with it. So it's not all doom and gloom. We can build reserve in older adults. And honestly, I'm telling you something you already know, but just for the audience, is that we know the best reserve builder, even in 80 and 90-year-olds, is exercise. It's amazing.
So, piggybacking on that, what do you think with people with exercising? I mean, we all know that exercise is wonderful for older adults. Do you think exercise is actually going to impact resilience down the road? You know what I mean? Like you're saying with if people do more exercise as they get older, or if they stop exercising, their exercise around COVID COVID vaccine times. What's your thoughts on that?
Yeah, are you talking about exercising across the lifespan or?
You pick. I actually think exercise is so important. So anytime somebody brings that up, if we could push more exercise, even if you're in your 80s and you want to avoid, shingles, you know what I mean?
Yeah. Yeah, I think the answer is yes. I think we have data for both ends of across the lifespan that chronic exercisers build a reserve better, and it pays off even in your 80s and 90s. And that individuals who have been sedentary and don't have much in the way of physical activity, even when they start an exercise program in their 80s and 90s, it has remarkable effects on longevity. I mean, there are a lot of groups that have shown that. One of the groups is based at the Durham VA at the GREC. It's called Gerofit. This is a program that was put together by Miriam Mori, an exercise physiologist in the 80s. And we've had now, close to 30 to 40 years of follow-up with these individuals. And the Gerofit's been disseminated to 50 VAs around the country now. It's incredible how it's done, and robust data showing improving not just longevity, but in maintaining independence. And interestingly, it reduces medication use, and people who are exercising tend to get vaccines, and they have less vaccine preventable diseases.
Well, it's great. No, anytime we can talk exercise. We have a great question from one of our audience members. The question is is there an epigenetic fingerprint that predicts vaccine responsiveness?
Yeah, what a fantastic question. And the answer is, I don't know, and I don't think it's been investigated enough. You know, epigenetics is really an interesting area because everyone says, oh, you got this set of genes and you're stuck forever. But clearly the environment and things that happen can influence that genetic response. So I'm not aware of it, but it should be looked at.
Great. And so I'm just looking if there's any other questions from our audience. Otherwise, thank you so much, Dr. Schmader, for your talk. Northwestern loves you. Anytime you want to come back and hang out with us, you know, maybe go to a Cubs game or a Bears game, depending on the season. We'd love to have you. But once again, cheers to you. Thank you so much for all the awesome work that you're doing for our seniors. And thank you again for giving our Geroscience Grand Rounds. Thank you, everybody, for attending. Thank you, Ken.
Thank you very much, Lee. See you.